It's nice to see so many nice faces in the audience. I think most of you know me. For those who don't, I am a pediatric endocrinologist at Great Ormond Street Hospital, and I have an interest for neuroendocrine disorders. So I look after patients with brain tumors who have had the consequences in the deep midbrain, and that's what I'm going to talk about. But I also look after patients with congenital disorders, so patients who are born with maldevelopment of the same brain areas. So my interest is strongly anatomical in a way, so how these areas of the brain, what happens to these areas of the brain when they don't work, regardless from what tumor, what treatment, etc. And I've been doing a PhD on the last few years on that, as I will explain. All right, so the first thing to say, I think the first message to pass is that differently from 30, 40, 50 years ago, these brain tumors are to be considered in the majority of the cases, not all, unfortunately, but in the majority of the cases, chronic lifelong conditions, okay? And this is something that I think the families deserve to know on day, maybe not on day 1, but on day 10 or something, after the big things have happened. They do deserve to know that. Most of the patients will live with the tumor or part of the tumor still there. For those where the tumor was completely resected or cured, they will live with the consequences in the brain injury that they have experienced. So there has been loads of progress on survival. I mean, this is just one of our studies on optic-pathway glioma, where the survival rates are, 90%, at least, up. You cannot see anything here. There is a very light gray line, trust me on my words, up to 15 years. But then this is the number of progressions and, the numbers of issues that these patients experience. So the more the curve goes down, the more issues you have. So at least in the past 10 years, when I've been around, in this field, I have seen lots of emphasis growing on the quality of survival. This does not necessarily imply that US families see a huge difference straight away, but definitely there is more awareness and there is more talking, about it. So specifically when the tumor happens to be in the midbrain, so this area between the eyes, the pituitary, the stalk, the hypothalamus, the thalami, etc., the injury, the greatest contribution to quality of life is hypothalamic injury. So people have seen these graphs multiple times. For those who haven't, essentially the hypothalamus is this purple area here, which displays, if one wants to be schematic, right? It's not so simple, 2 main functions. One is endocrine, so it controls the pituitary gland through the stalk, which in turn is the post office that releases messages to the entire body and let all the glands, messages to all the glands out of the body to work. And then the other functions are actually more complex. I've called them neuronal. This is not exactly the term to explain all the function, but essentially they involve regulation of appetite, thirst, sleep, memory, but also emotions, also behavior, okay? And this is why you have this this book here, I Love You, from the hypothalamus, because the hypothalamus, as I will tell you, produces one of the hormones called oxytocin, and I know there are people in the audience who have been completely aware of this hormone, which involves our ability to bond, to love, and to, basically our social skills. To do that, the hypothalamus connects not only with other brain area for more complex functions, but within the hypothalamus itself, there are several regions and nuclei that talk between each other. So the hypothalamus is not to be considered like a single brain region, but more like a conglomeration of different areas, if you want, and they need to talk between each other to display function. So this is incredibly complex, okay? And this is the reason why we are so limited in our ability to tell you as families what your specific child chances are of developing such a degree of hypothalamic injury and which aspects of the multiple vital function of the hypothalamus your particular child is likely to develop, okay? So this involves everything. So we don't know exactly in each type of brain tumor what is the prevalence of hypothalamic dysfunction. Some data are coming, out, but we still don't have a complete picture. We do not actually have diagnostic criteria. So if I talk to another person and say, do you consider this child to have hypothalamic dysfunction? It's not that there is X, Y, and Z number of criteria. We can say, yes, definitely this patient has. It's more of a likelihood risk score type of things. And this has made it very difficult on oncology trials to actually put something that would tell us in 10 years' time what this specific treatment has given, better or worse in terms of hypothalamic dysfunction. We do not have easy biomarkers, so it's not that we can go and have a blood test for thyroid function and we can tell your child, yes, your child has hypothalamic dysfunction. And on the imaging, I mean, that's where I spent, the last few years of my life. It's incredibly difficult to study the hypothalamus. One, because it's made of different regions. Second, because the boundaries of the hypothalamus are not so well defined as for other brain regions, okay? So what are the implications of all these uncertainties? Well, number one, I told you already, we cannot do precision medicine. We cannot counsel the families in a way that will help them understand exactly what their child will develop and how long down the line. We struggle to monitor. It's difficult to develop targeted treatment and the preventative strategies, and that's what success is about and advocates. It's very difficult to justify rehabilitation, when we don't really understand, completely, hypothalamic injury either. So these are the funders of my PhD. Children with Cancer UK was the main funder, and Success has also helped, funding my PhD fees through the years. So the data that I will show now are just some basic data from my PhD. I haven't put anything, statistical, mathematical. I just try to make it very simple so everybody could understand. Essentially, I did three things in my PhD. One was to look prospectively, so to ask the families prospectively the degree of hypothalamic injury their specific child has experienced. And to do so, it was complex. It was a combination of questionnaires, history, objective measures, so it took quite a while. So the numbers that you see in red here are done this way. So it's not going through the notes retrospectively, it's actually me sitting with the patient, and asking specific questions. So the degree of hypothalamic injury in mid-brain tumors is exceptionally high. Okay, so you can see, depending on how stringent you are, how severe, you can see that hypothalamic injury is between 70 and 85% of the patients. So we can say to the patients, you are highly likely to have some degree of hypothalamic injury. This involves 86% of hormonal imbalances, which have short-term consequences, but also long-term consequences. And we heard this morning about fertility, etc. I found that the degree of appetite disorders, when you include everything, not just the severe, disorders, morbid obesity, etc., is between 40 and 70% of the patients, and we know the long-term consequences of that. Slightly less when it comes to sleep and temperature regulation, but bear in mind, not everybody's under a sleep specialist, okay? So I think our ability to make diagnosis, especially in milder cases, is limited, and temperature is such a difficult thing to measure. I mean, of course, if the child has hypothermia, low body temperature, or hyperthermia, but, those thermal sensation disorders, when they come to me and they say, oh, it's hot outside and it feels cold, or the other way around, are more difficult to measure. And this is obviously the striking thing. Learning and mental health difficulties are highly prevalent, okay? And again, definitely this is underestimated as well. Although I did it prospectively, still, I'm not a mental health specialist, and obviously, there are definitely patients that are going to be underdiagnosed. And then there is this blue thing, the fatigue, okay? I don't know, if you are a brain tumor survivor, so you have not experienced fatigue, can you raise your hand? I mean, I have personally never looked after a patient with brain tumors who doesn't tell me, that they experience fatigue. The commonest encounter is a patient who has undergone radiotherapy, okay, proton beam therapy or the standard radiotherapy, and they come and they say, oh, I just fall asleep, I just cannot do anything, etc. But that's not the whole picture, okay? There are definitely patients who have never had radiotherapy in their life. They have tumors involving the hypothalamus, and they still experience fatigue. So what is this fatigue? It's probably a combination of lots of different things, which is going to take a long time to talk about. It's hormonal, it's nighttime sleep, encompasses several aspects, okay? But definitely this is something that research, should bring forward in the next few years. There are no specific questionnaires, that we can administer, and there are in different fields, and there is one example sitting in the room of a patient who has been, diagnosed ultimately after a very long journey with excessive daytime sleepiness, like a variant of narcolepsy, and is being very successfully treated with methylphenidate, but it was a very long journey, to get there. And yeah, this patient will fall asleep, and if the mom is happy to share their experience later, she's very welcome to do that. So this is what hypothalamic injury is, okay? So, and what I also looked at is the pattern over time. So I asked the families, what do you think? I mean, do you think this is getting worse, better? If we want to measure the trajectory, okay? Because these are lifelong conditions. What's the natural history of these disorders? In most of the cases, there was worsening over time, okay? Things didn't get better. The only instance where I found an improvement was in the visual symptoms, and this is because oncologists and neurosurgeons are so good at preventing, further deterioration of the visual symptoms, but all the rest got worse in the majority of the cases. Okay, so this is some questionnaires that we use to measure quality of life. This is not perfect whatsoever, but is one of the standardized measures in pediatrics we use to try and pick how much of a problem is for the child to do specific things. So there are 4 aspects. One is physical, social, school, and emotional. And when you pull these things together, you get 2 scores, one mainly for the physical functioning and one mainly for the psychosocial functioning. So I told you that I look after patients with congenital disorders as well. So these diseases are not all brain tumors. So the first 3 are cranopharyngioma, optic-patuloma, germ cell tumor. Then I had the hamartoma, cyst, and then these are all congenital disorders that I don't want to talk about, but I want to highlight 2 things. One, as you can see, the 5 conditions on the right are similar in terms of scores to the ones on the left, and this is already telling me that it's the injury to the hypothalamus, is not if the fact that it's a cancer or a brain tumor causing it. And then this line is the normal pediatric population, so essentially nobody has a perfect life, okay? So 100 is the maximum, but obviously everybody has problems, nobody has the perfect quality of life. So if you administer these questionnaires to healthy age-matched individuals, the score will come up just above 80, okay? So most of these conditions are significantly below, okay? I know everybody knows, but it's good to see it on a graph and document that. What are the drivers of quality of life? Without showing you too much statistics, the main drivers were these aspects: appetite disorders, sleep disorders, learning and mental health, but also the neuroendocrine function. I know we hear lots of families who manage very well the multiple medications, they know what to do in case of an adrenal crisis, they know what to do if it is hot with the desmopressin, etc., but it is not easy, right? So it doesn't help quality of life when you need to get 5 medications and you worry about fertility in the long run. So all of this came back significant. What didn't come significant was the vision. And this is a bit of a strong statement. I think it's number 1 because except few unfortunate cases where vision was completely lost and could not be prevented, in the majority of the cases, vision remains acceptable. And we heard this morning, about the struggles with lateral vision, etc. It is a problem for sure. But I guess what this points out is that all the other problems together in the attempt to prevent vision not necessarily make quality of life, easy for these patients, okay? So I think this is all I have to say, on that. So how do this data compare with other chronic conditions, okay? So do children with midbrain tumor do similar to a child who has asthma, cancer, obesity, and other things? So there is this study, maybe an old one, but I thought it was a good sort of example, which uses the same questionnaire, and you can see here the average scores. So in our cohort, this number was 52, and the lowest is the worst, okay? So if you compare these scores to children who have simple obesity, not caused by tumors, just obesity, or to children who have any type of cancer, this involves tumors, leukemia, and cancers all over the body, or for example, psychiatric disorders, so patients with midbrain tumor, because they have all of these problems together, right? They do worse than all of them. And the only one which was actually comparable is children with cerebral palsy. So I found this quite self-explanatory. This is a brain injury, and the quality of life of children with midbrain tumor is comparable to children who have cerebral palsy. Okay, so few words on what I've done in terms of imaging, on the hypothalamus. Because the hypothalamus is made of different regions, and we can kind of predict the function based on the functional anatomy of this structure, I have essentially gone through images to determine the level of regional damage of the hypothalamus. So it's like you cut the brain from the front and you take different slices. So you need about 10, 12 to cut the whole hypothalamus. So in the population enrolled in my study, I have gone through these images, and depending on where the level of damage was, I have correlated, the problems that the patients experienced. Okay. Yes. Oh, 1 minute. Okay. Oh, I thought you had the question. I was like, okay. Okay. It's okay.
Sounds like the next speaker is going to give you a couple of minutes.
I'm gonna try to wrap up. Thank you, Melanie. Okay, so two things I wanted to say. I mean, I have started to learn, a lot about, the phenotypes of the patients by doing that. So what I found in my population is that if the tumor is more anterior toward the eyes, okay, you are more likely to experience problems with the neuroendocrine function, temperature regulation, and learning. And this is where the nuclei of the hypothalamus displaying these functions have. If you have more problems in the middle region, which is the blue, the tuberal, you are likely to experience problem with the appetite, the thirst. If you have more problems in the back, on the region of mammillary bodies, you are more likely to struggle with emotions, mental health, and sleep. I think that's quite helpful, for the families to know if we are able to predict that. I also look at the white matter fibers that cross the hypothalamus. I don't know if you can spot these white dots, among this is the hypothalamus, this gray area. I mean, abnormalities of these regions were associated with memory, which is another big, huge struggle, in these populations. And I also measured the volume of the hypothalamus, but I'm gonna just skip that because I wanna be able to tell you a couple of things on this. And I measured biomarkers of disease as well. So a couple of things, because this opens the door to some other talks that are gonna happen later. Sometimes we struggle to make a diagnosis of AVP deficiency. Some of you have this condition, so you know what it is. So there are some novel markers that can be used to make this diagnosis quicker, after, your child has had an operation on the ward, etc. One of these markers is called copeptin, and I found it was, quite a good marker at making a diagnosis, and I'm not going to go through details too much. Oxytocin is the hormone I alluded to at the beginning, which helps us bond, and we do see significant issues with social interaction in patients who have had midbrain tumors. Is it possible that this is linked to a lack of oxytocin in the hypothalamus? But most importantly, this is the question from another person who is sitting there in the room recently in clinic. Is it possible to replace this the same way we give thyroid hormones, the same way we give other things, and improve the ability of this person to make friends, to have meaningful relationships, etc.? There are several groups working on this, and I'm just going to leave you on that. And then the appetite is the other aspects. I mean, many patients develop hypothalamic obesity, so I've been studying all the circuitries within the brain and the gut that regulates our ability to stop eating and to start eating, and measuring all these hormones. It was a bit of a mess because every single patient had different patterns. It's very tricky, and it's going to take time to explain, but all I can say is that not all patients who become obese have hyperphagia, have excessive eating. It is more complex than that, okay? As we were doing all this research, the clinical trials went ahead, and actually we now have a clinical trial running Gosh and other institutions in the UK where we are targeting a treatment on a particular pathway acts on the receptor of these hormones that tell us stop eating in brain tumors. I don't have the final results yet. We need to look obviously at the end of the trial, but it looks very promising. So even this thing that, such a big issue, I think it's going in the good direction. So to conclude, and sorry for taking a couple of minutes from Melanie, we have documented prospectively that midbrain tumors carry a very significant hypothalamic morbidity, and this involves multiple domains. It cannot be just me, just Darren, just Melanie, just this person. I mean, it needs to be multiple professionals working together because unfortunately it's multiple functions, and also we have learned that this worsens over time, evolves, okay? So you are to be expected to have a good transition and, all the implications that this has. Unfortunately, quality of life is poor, and we already mentioned that. I think it is very important to do such studies on hypothalamic injury. It's not the easiest topic to study, but obviously if you don't understand where the injury is coming from, it's very difficult then to act on it, okay? And then unfortunately, there will be some patients where the damage is done and it's irreversible and it's already there, okay? So those patients, it's unless we are able to prevent the onset of a tumor, which I wish will happen, ever, it's very difficult to avoid this damage. So our job would be, number one, to avoid further damage or to try to minimize further damage as much as possible, and number two, to rehabilitate and to provide all the support, because unfortunately, that's the only way you can bring, children to full life potential. On the first topic, pituitary dedicated services have been already mentioned, on the surgical side. I mean, last week, everything I've learned as a doctor, I learned from parents, okay, and the families. And every time I give a talk, I need to state some of the quotes that the patients teach me in clinic. And this is just a patient from last week who said, unfortunately, my son had a tumor in an area that we cannot replace. Most of the organs you can replace, you can remove a heart, you can remove a lung and change it. But for the brain is who we are. I mean, even if it was technically possible to remove a brain, we would never be able to do that. So once the injury is done, we can only rehabilitate, and etc. And it's not just palliative, it's actually ensuring that the child has the full potential, and that's why, all Success is doing is so important. So thank you for listening, and happy to answer any questions.